When we're talking about the function of the heart, it's important that we understand how our cardiac output is determined. We know that cardiac output can be calculated. The formula is stroke volume times heart rate. There are three things that affect stroke volume. They are preload, afterload, and contractility. We generally think of preload as the amount of blood contained in the chamber of the heart just before the heart squeezes its muscles and contracts the blood out of the ventricle. That can be measured. And so oftentimes you'll see textbooks talk about preload in terms of the number of milliliters contained in a ventricle. They might use language like end diastolic volume, and this is all correct. But when we think about preload in terms of the patient's ability to function and the heart's ability to perfuse oxygenated blood to the body tissues, it's better to think of preload in terms of a person's fluid volume status. I like to use a fish tank to explain how the heart works and how we can manipulate preload, afterload, and contractility. I have a fish tank. I've got our friend Squidward, and I have Miss Sandy Cheeks. And the idea here is that they represent the organs that our heart has to perfuse to. These are our end organs, so the kidneys, the brain, the lungs, the liver, and actually the heart itself. If I don't have adequate cardiac output, I'm not going to have adequate perfusion. In order for this fish tank to operate and in order for our heart to pump, we need adequate electricity. And the electricity that drives our heart to pump are our electrolytes. So this power cord I've labeled with our cardiac electrolytes: potassium, magnesium, calcium is also a cardiac electrolyte. So I'm going to start by pouring some water into the tank. This is how we optimize preload. So, as nurses, when we administer IV fluids to our patient, what we're really doing is increasing their preload. The mechanism of the pump represents the heart's ability to contract. So here we see that the pump is functioning. I've got water coming out of the pump, but Sandy and Squidward aren't fully submerged. They're not being adequately perfused. So I have options. I can try to increase the pressure of the water coming out of the pump, but it's not really going to change the fact that they're not submerged in water. So here, I actually probably need to give them more water. I need to improve my preload. You can measure the amount of fluid that your patient has. It's part of our hemodynamic parameters that you're going to learn more about later in this course. But for now, just know that when your patient seems dehydrated, they probably need fluid. And that before we can manipulate afterload and contractility, we need to make sure that we filled up the tank. So for your patients, this is giving them an additional bolus of normal saline or lactated ringers, whatever's indicated for their situation. And now that I've improved preload, I've also improved output from the pump, and I have adequate tissue perfusion. Sometimes that's not enough. Sometimes I can optimize preload and my contractility is weak. This is what we're going to be talking about with heart failure. So I may need to improve the quality of the pump itself. Now I don't have one, but to change contractility would basically mean to change out this pump and put a higher quality pump in there. In patients, these are our inotropes. Medications that alter contractility include digoxin, as well as dopamine and dobutamine. My third way that I manipulate stroke volume is through afterload. So preload was the amount of fluid in the tank. Contractility is the ability of the pump itself, powered by electricity. But I could also increase the resistance that the pump has to overcome to send out the water from the fish tank. In the heart, this would be the resistance the heart has to overcome for the blood to leave the heart. Most textbooks will talk about afterload in terms of the amount of blood left in the heart after it contracts. The better way to think about afterload is resistance. How much resistance does the heart have to overcome in order to get the blood out? Sources of resistance in the heart include the valves themselves. So in the left ventricle, that's the aortic valve. In the right ventricle, that's the pulmonic valve. And they also include the vessel. If maybe my aortic valve works just fine, but as the blood leaves the left ventricle, it enters the aorta. If the aorta is constricted or dilated, that's going to affect the amount of resistance the heart has to overcome. Similar to putting your thumb over the end of a garden hose increases the pressure of water coming out. If I increase the resistance of the water coming out, it's going to leave with a higher pressure. Sometimes we want to do that. In that case, we would be administering pressors, such as dopamine, dobutamine. Other pressors include norepinephrine and neosynephrine. You'll learn about those later in the course when you get to shock. Sometimes my afterload is too high, and I want to decrease afterload. Then I would need dilators. Your nitroglycerin, nitroprusside, to some extent the calcium channel blockers, so nicardipine is the IV version. Afterload is often measured in terms of your blood pressure, right? Because if the amount of resistance that the heart has to overcome is affected by the constriction and dilation of the blood vessels, then my blood pressure, my systolic blood pressure, is going to be a reflection of afterload. So you know someone's afterload is high when their pressure is high. Someone's afterload being low, their pressure's low. However, remember that blood pressure is also affected by preload. So sometimes if someone's blood pressure is low, a simple fluid bolus is enough. Increase their preload, improve their cardiac output. These three factors, preload, afterload, and contractility, are essential to understand when you talk about anything to do with cardiac output, which includes heart failure, and later in this course when we talk about shock.